online program. Today's topic is universal healthcare through primary healthcare, more crucial than ever. Currently, the term universal healthcare from the term universal healthcare, the second part was deleted and it was substituted by universal health coverage. Coverage means only financial protection. Thus, most of the government's role is changed to healthcare provided to healthcare purchasers. In this context, so the organizers of this program deliberately use the word universal healthcare instead of universal health coverage. And the second part, through primary healthcare is now important strategy to attain for universal healthcare, which was coined in 1978. In the currently commercialized way, we are deviated from primary healthcare. But after 30 years, in 2008, World Health Report again reminded us the importance of primary healthcare more than ever relevant. And through the Astana Declaration, again PSC was again restated, and primary healthcare is not a second care rate. Today, our speaker is Yogesh Jain, one of the leading experts available in India about the subject of primary healthcare. And he was technically or professionally, he was completed his medical education at All India Institute of Delhi and completed his MD, also PhD pediatrics in Delhi in 1990s. And inspired by the principles of primary healthcare, especially inspired by the principles of social justice and equity and community participation, and by understanding the political economy of health and illness in India, he left the lucrative job as an associate professor in All India Institute of Medical Science. And he lived in the state of the poorest state in India, Chhattisgarh, and founded and run people-centered healthcare centers through the NGOs, Janasastu Sahayog and Sangwari. And he is now living as a public health physician as well as public health researcher through his experiments with people. And through his research works, through the results of the research works are used for our national level for programs as well as national policy. For example, the supplementary nutrition in TB programs were introduced in RNDCP. It was by his and his teamwork, a cohort study. And recently the alternate regime in daily regime in TB was converted to daily. It was alternate regime was converted to daily regime. That was one of the pioneering work of he and his team. And he has got more than hundreds of publications in reputed international journals. And he also served as an expert committee member in the advisory expert committee member in the planning board as well, planning commission as well as NHM in various national programs. And he is one of the member of the high-level expert group for universal health coverage in India, HLEG, and which formulated the clear roadmap of India towards universal health coverage without any health insurance, but exclusively based on public funded tax. So I invited Yogesh Jain for his deliberation. His presentation will be for 45 minutes. First part, he will explain about the concept of universal healthcare as well as primary healthcare. And second part, he will share his experiences as well as experiments in delivery of true primary healthcare. And according to him, the primary healthcare was not a secondary healthcare. And all participants are requested to keep their keep the mute mode, and they are requested to keep their video off. And during this presentation, you can post your comments or queries in the chat box. So I invite Yogesh Jain for talking about deliberation about this subject. Yogesh, please, you can present.
Yeah. I'll just come in. Thank you so much for this, I would say, undeserved sort of an introduction that you prefaced my presentation with. And I must say, I heard the word universal healthcare first time in 2010. After I had spent close to 28 years as a student and as a practitioner of public health. And even though primary healthcare that we had heard as a slogan from when I joined medicine in 82, sorry.
There is some technical issues. We can wait.
Yogesh's mic is muted. Yogesh, we could not hear you. Yogesh's mic mute ചെയ്തിരിക്കുകയാണല്ലോ.
Yogesh, please, your mic is muted.
Can you hear me now? Can you hear me now?
Yeah,
Yes, now it is
we
audible.
can hear you. We can
Now it
hear
is
you.
audible.
In between whatever you said, we could not hear. So you'll have to repeat it. Just.
Yeah, so I will do that again. You can see my slides, then that makes me feel okay. And
Yeah, we can see your
I
slides.
was trying to see. Thank you. So, universal healthcare is an idea that I first learned in 2010, and primary healthcare was already becoming selective care in as early as 1983 when I was still a medical student. And for me to understand, I'm a practitioner of primary healthcare. I'm not actually an academic in public health and whatever I've learned is actually by practicing and by observing what one has seen in some of the poorest parts of the country. And there, if I want to sort of discuss to this gathering that I see so many friends in, for me to revise what universal health care or coverage is.
Again, problem, Yogesh. We can't hear you.
Maybe network issue now. He's coming back. Yeah, Yogesh, we can see the slides, but we can't hear you.
in the program. In the Zoom, it is you are not audible. What happened? Please look. Okay, right. Slide. I will ask the other person to do. Okay. Oh, my. Okay. I will get. Jagdish now. I will ask Jagdish now. Okay. Hello.
കേൾക്കാൻ ജയകൃഷ്ണ പറഞ്ഞോളൂ.
ജഗു പിന്നെ നിങ്ങളുടെ കയ്യിൽ സ്ലൈഡ് കൊടുത്തിട്ടുണ്ട്. Slide share and he will come through the phone now. Because of the net problem, I contacted him. He has sent the slide to you.
Can you hear me now? I'm now through a phone connection.
You are audible. You are audible.
Yeah, you are audible. You are audible.
Okay. Can you run my slides? You know, it will be difficult for me to do it. I sent the slides to someone, two people. Anyone who can run this slideshow. I think I've sent to this number called. I think it's your number only that I sent you to, didn't I? 9447953005. Just a little while ago. Hello.
നീയെ ജഗദീഷ് അത് ആ ഷെയർ സ്ക്രീൻ ഇല്ലേ, അത് ഓപ്പൺ ചെയ്തിട്ട് അത് ഷെയർ സ്ക്രീൻ കൊടുത്തൊന്ന്, അല്ലെങ്കിൽ ജയകൃഷ്ണന് പാസ് ചെയ്യും. എന്തെങ്കിലും ടെക്നിക്കൽ എറർ ഉണ്ടെങ്കിൽ ജയകൃഷ്ണന്റെ അവിടെ നിന്ന് അത് ചെയ്യാൻ പറ്റുമായിരിക്കും.
Well, it's not my number. It is not my number.
The number is 9447953005.
Okay, then whose number is that? Suresh, Jayakrishnan, Krishnakumar?
It says the organizing team. So I just sent it about 10 minutes ago. In any case, I sent it to another person called Dr. Rangaswamy. If she can run it, I had a.
Okay.
But it is in my phone. I am not able to manage it.
Yogesh, if you can speak, I know that you can speak even without slide. You can continue to do that, Yogesh. No problem.
Okay, I can do that. Yeah, I can speak.
You can do that. I think you can do that.
Yeah, later you can share the slides.
Meanwhile, we will try to.
Right.
Meanwhile, we will try to upload it. Okay.
Yeah.
Okay, so I was saying, universal health care is basically looking at the determinants and then also providing care for all the people who should have access to full range of of services of people, what the care that people need, and when and where they need them without financial hardship, and it should cover the full continuum of essential health services from health promotion to prevention, obviously treatment and rehab, and even palliative care. And if you look at the 10 guiding principles for universal health coverage or care that we sort of enunciated about 12 years ago when we were doing the high-level expert group in the for the Planning Commission, the 10 principles included universality, equity, non-exclusion, non-discrimination. The word comprehensive was also there. That is care that is across the continuum of the requirements that a particular illness or a particular person requires. That is rational and is also of high quality. There has to be financial protection. There has to be protection of patient rights that guarantees, appropriateness of care, patient's choice, portability of care, and as well as continuity of care. Consolidated and strengthened public health provisioning, and accountability and transparency, community participation, and putting health in people's hands. So these were lofty objectives, lofty principles that were sort of determining UHC in a sea when there was always selective care that was being provided at that particular time. So if you are on this slide, I think this slide is after this there is another slide. Yeah. So so therefore I would say I wanted to make this statement. Can you go to the next slide? Someone who's showing the slides now. Next one. Yeah, next one. Next. Yeah. So basically, all these principles that I talked about, and I want to make this first big statement here that when you talk about healthcare for all, let's face it, this is a socialist project. It cannot be a capitalist project. It cannot be whatever else. These are all principles of of a socialist world. You cannot. It has never happened that you have provided healthcare for all in any non-socialist sort of health system or a non-socialist society. Nowhere in a privatized world have you been able to provide universal health care, and it's also not likely to happen unless people are very, very equal and all people are very rich. So it's actually a socialist project. So can you go to the next slide? So this idea that this vision, if you can call it access for all residents, migrants or citizens of income level, social status, gender, caste, religion, all the reasons axes along which we have inequity in this blessed world, and of assured accountable care. And this thing that was being pushed in, that the government will only be a guarantor and enabler, not necessarily the only provider, but certainly the major provider. This is necessary in any version of universal health coverage. But once you look at the primary determinants of health, then it will become care then. So if you look at it, this is such a lofty and a pipe dream sort of a thing. When you look at what actually happens in universal healthcare, forget about there is no universality in terms of access to the uncovered people. Hardly any people are covered for their basic needs, and all illnesses are not covered. You might get some care for say hospitalization, but what about outpatient care? If in most of these insurance programs, and thirdly, it does not prevent a loss of wages and people becoming poorer. So across the three major reasons why universal health care would be thought of, even in terms of healthcare provision, not forget about the determinants, the financial protection, but even universality of of everyone being protected, or all services that people need are looked after, we fall far short. And let me just take next slide, if you can show what this concept of universal health care, what are the challenges that it faces. Let's look at the bad world that we live in. First, are we ready to invest money? The answer is we still haven't agreed to invest the right amount of money. No one has been able to provide universal health care if it is spending less than 3% of the GDP that is being spent in this thing, and we are not ready to spend it. Even in India, we are still at 1.1% or 1.2%. Second, are we politically committed to serve everyone? The answer at the moment is in a world where everyone eulogizes privatization, we are not politically committed to serve everyone. Third, is investing in healthcare is considered a worthwhile investment? I don't think that there is a societal acceptance to this idea that if you spend money, then it is going to cause investment. It's a worthwhile investment in terms of having better people. And unless you have this sort of a mindset in a society, in our political in discourse, that this concept is not likely to come in, is what I feel. And fourth, are we ready to make public systems a predominant provider? This is clearly, even the people who are supposed to run the public systems are at the moment the strongest advocates of privatization. So whether it is the bureaucracy or whether it is even the political establishment. Fifth, so whether it is services. So you look at the privatization that you see. We are trying to privatize the health system services. So district hospitals getting privatized is another thing that people are looking at. Drugs, the most of the drug industry is still in the hands of the private sector. We are destroying our public system services for drug production. And finally, what is being discussed in everywhere, medical education being privatized. How in this situation can you even dream of, of universal healthcare? Next. So, and if you look at this, let's take a reality check. Next. So you'll have to go a little faster because I have too many slides. So, someone who's running it, please run faster. The burden of illness is, you look at illnesses are such high in numbers, and anyone who's working in the poor rural India will see the numbers are such high in numbers, whether it's tuberculosis, leprosy, malaria, getting replaced by dengue and scrub typhus, NCDs, of all types, not just the common.
Again, problem, Yogesh, we can't hear you.
Yeah. NCDs are such in large numbers, trauma, nutrition deficiency disorders, and also there are actually poor estimates of the burden of disease. That is, that plagues are all our health systems development. Tribals, for that matter, we don't even know what is the proportion of illnesses. Like, for example, tuberculosis, what proportion happens among tribals? We don't know that information. Effective health services are not there in large parts. ECG machine at a CHC or a PHC is not decided at the moment. Whether there should be a refrigerator in a village, how will you look after diabetes if you are going to be giving insulin to people and there are no refrigerators? And, relative numbers, snake bite deaths. How many snake bites are happening at a community level? We don't even know that data. We know that number of deaths are estimates, but number of snake bites, we don't know. And there is this trivialization and marginalization of all problems, whether it's NCDs. So the WHO only talks about 4 large NCDs, but doesn't talk about anything else. And there is this large number of NCDs that no one worries about. So you do a sickle cell screening in the country level, but don't ensure treatment for those who are diagnosed. This is the reality of this India at the moment. And you offer HPV vaccine to people, but you won't ensure that screening of cancer cervix screening is happening. So, and this entire thing about our program system development is we want to focus on efficiency or equity. And usually it is the efficiency that trumps, equity concerns that, that plague any sort of health systems happening, which are for everyone. So, and this, next, I really learned from my work that people in small places read that as common as, villages and, are further the villages and even the poor parts of cities don't have small problems. This entire idea that people should, in poor parts of the world don't require that much, technical care, or they require very trivialized care is such a nonsense idea that has, that determines, the minds of so many people who develop these health systems. And these, someone is going very slow about my slides. I'm running my slides even faster. So, these people who have these problems, big problems, they require much more technical expertise in poor parts of the country. And I would say poor people get poor health systems. This is also a fact that we have to grapple with when we are thinking about universal healthcare at all. So you talk about, health systems. The health systems are at the moment such poor in quality, public systems particularly, and people expect little from it. Though they still hope that, that people might, want better systems. So, and, if we go on to this slide called, where I talk about public health information, there is actually no good information system that we have developed. Neither there is an adequate surveillance system for, when we found that malaria, malaria numbers are going down, we have stopped doing the proper surveillance. In fact, we never did that well enough. Someone has to run slides faster? I won't tell now. So, and it takes time. So medical education, public health is such a huge issue now. Medical colleges are involved in mediocre quality MBBS training and not involved in public health, frankly. They don't, so we can run our public health programs through the health system, but medical education teachers will not contribute to the public health systems. You know, they will sit only there. They are gurujis who will train only people who come to their medical colleges, but not, they will not go down to the departments of tuberculosis or, you know, or malaria programs or whoever. So, and you know, A&M courses have stopped. I don't know who decided this thing. Like, go faster, ma'am. Whoever is running these slides. You know, these are, you're still 3 slides behind that I am speaking on at the moment. So, you know, and the 3-year course has been not taken up. You know, we started this this idea, but that has not happened till now. Go faster, and you know, protection from illnesses and impoverishment is not happening. So the Pradhan Mantri Jan Arogya Yojana is for only half the people in the country, and it is only for the inpatient care, and that too has so many administrative. And it is bandied around as, you know, as universal health care by the present government. There is lack of professionalism in the entire medical fraternity that I can see, and the system is completely unaccountable. So, you know, and if one looks at determinants, that no one looks after the determinants. Forget about food availability. Even salts and carbs are high in our food. The water is insecure. The water bodies are unprotected, and civic bodies don't do the work that they're supposed to do to sort of ensure, you know, good public health for the people. And, you know, even if you look at even the food things, you know, there is a pecking order in the amount of food that people can get to become, you know, nourished. So the people in the PVTG group will have lower BMIs than people with regular tribes. Dalits will have slightly better than OBC than in that order. So, you know, even as we are different, you know, human beings at a level of even getting the foods into our bodies. Next. So, and, you know, if you look at the health bureaucracy is not supervising adequately. There is opacity in posting, recruitment and transfers, as we can see, and private practice is causing conflict of interest and a hemorrhaging of the system. So, and so then what are the other challenges in getting universal health care? The public health system has very low self-esteem also. And even we don't have, you know, the expectation or hope from the public health system. There is shortage of staff that we see. There is political commitment is, you know, is poor. Financing is, you know, an issue. And we don't have a well-functioning technical support unit. And finally, I would say there is a low spirit level among people. And what are the other challenges that people face? The health system, UHC faces tertiary care, secondary care, and primary care. So we have decided that we will palm off the secondary and tertiary care to the private sector and only look after primary care, even primary level care. I'm not talking about primary health care at the moment. An insurance program is being the dominant idea among many people that this is going to provide, you know, some amount of modicum of secondary care and tertiary care. And there are vertical programs that run, you know, whether sort of parasitizing on the horizontal system programs, and, you know, working on social determinants is not happening. So, you know, if you look at it, Thailand and Costa Rica are 2 countries in the world that have got UHC done for their people, but even by less amount of money. And obviously, some richer countries which are also developed these socialist systems called in UK, Brazil, Canada, and Australia. And, you know, if I want to discuss here, my large idea is, why is privatization not the way to go? If we look at it, the private formal system only thrives actually on ineffective public system. But you can look at it, it does never go to the areas where there is no public health system. They are only there where public health systems are ineffective, and, you know, sort of in thrives on that. But areas where public system is also not existent, private system does not go at all. And all such attempts where it was empaneling private laboratories to run health services, like in the PSCs or CHCs in Madhya Pradesh or in Chhattisgarh, to run the mobile medical units, has not worked out. And people are, you know, forced to make a choice. You know, actually, there's no choice to go to the private clinics and hospitals for both outpatient and inpatient care. But if the public health system is sick, I think that one has to work upon it, not to throw the baby along with the bathwater. What is the way at the moment that is a dominant idea. So I think there is, and in nowhere in the world or any state of India has a private system provided equitable healthcare to anyone. So as I repeat again, healthcare for all is a socialist idea. And, you know, allowing public physicians to do private practice has been a disastrous policy since the conflict of interest physicians have is they don't encourage people to serve well in the public facility. And we have seen it all in all places. And I would say, if we talk about universal healthcare, how can it come? So this is an idea from Thailand that I learned. If UHC has three angles of a triangle, so one would be, one is do we know how to get universal healthcare for our people? I think we have the nuts and bolts of how can do it. So knowledge and evidence for that is there. We require political commitment and will, which at the moment is lacking. But equally important is, there has to be a demand for this. It has to be, you will not get this sort of a, right unless you ask for it. And I think in that sense, our social and civil movements have not measured up to this idea that we are sort of debating today. So if I may, go on, before I go on to primary healthcare, if I may ask this question, is universal healthcare only a pipe dream, or is it really a practical objective? I think there are some top objectives that we can get some amount of, universal healthcare. So first, we can ensure even at least this much, all essential drugs are available and all are being offered in government facilities. You will certainly find that at least 70% of universal healthcare you can provide once you get all the drugs and they're offered in all government facilities, down from the medical colleges to the health and wellness centers or to the ashas at the community level. So there should be no stockouts and shortages. That is the bare minimum, certainly. The second bit that you can do very well to get a lot of universal health care would be to ensure that all essential investigations are also available and are offered in government facilities. I don't think that is one place where we are hemorrhaging the private system, the public system, by offering it in government facilities. Look at the entire state of Madhya Pradesh. They've farmed out the entire investigations to the private sector, and that has been done at the highest level from Bhopal. All their CHCs, PHCs, district hospitals are all their labs are being converted there, and even the lab technicians who are part of the health system are twiddling their thumbs. And I would say, removing all user fees in the public system is another thing that we can do. I think banning private practice by government doctors is going to be really working. And at least we can start by banning it in bigger towns than all medical college towns. And there may be a movement towards smaller districts if that can happen. And I would say these are beyond, just band-aids for getting universal healthcare, but at least this could be a beginning, if not the end. Will improve, care in the district hospital and medical colleges. But I think an equally important thing, if we going to ensure, universal health care in any form, is to get into having states, and I would say, why not the nation getting into a right to health act, healthcare. Without this, even if you ensure the so-called Mai Baap Sarkar providing universal health care coverage, this might fall through unless it is it is justiciable and people can ensure legally that they get care. So this is an important bit. Otherwise, UHC is going to be continue to be a pipe dream. So if I may go to the second bit, this talked about what is primary healthcare approach. I don't think anyone in this chat wants to talk about primary healthcare, which might be conflated with primary level healthcare. So primary level healthcare, there are some essential components. Are you hearing me or no?
Yeah, we can hear you.
Others, please keep
mute. From somebody's, please switch off all others, their mic.
Okay. Yeah.
We can hear you, Yogesh.
So there are some, important components of primary healthcare. Can you show the first one? Empanelment. Every person, a citizen or a resident should know who is their health provider. And every provider should know who is the person, who are the community that they have to sort of respond to, without which, you will not be able to sort of ensure this approach will be short. So, this is a requirement that if you have 10,000 people or 1,000 people, or surgeon should know, who is my catchment area 5 lakh people, and every person should know who is the person, who's a surgeon also, not just a medical officer or a A&M. who's supposed to be responsible for my care to ensure the continuity of care that later that will happen. And the second bit is, if you really get into a primary healthcare approach, is a comprehensive assessment and in fact a risk stratification of the community that the health providers should ensure in their own sort of empaneled community, so that you can decide what care to give to which one. And I would say comprehensive care has to be part of it. Therefore, this word now, comprehensive primary health care, is the bandied word around, which is continuous. You can't be providing, and it has to be bidirectional referral pathways. So if a person has symptoms of hypothyroidism, one can refer up for an investigation like thyroid function test, but the reports can come down and the treatment can be continued by even a CHO or by even an ASHA. Why not? And navigation support has to be part of this comprehensive care. Otherwise, you can only have, people can fall through the cracks. And technology is also useful. So I'm going to talk a little bit more about it. Technology, instruments, knowledge, and in fact, information technology also. Care protocols and supervised knowledge is necessary bit about ensuring a good primary healthcare approach. And primary healthcare approach is, is also next slide is also accessibility is a fifth pillar of primary healthcare approach. It has to be community based. You cannot expect people to go down to for a problem like a fracture to go up to a medical college, or a pneumonia which requires oxygen and IV fluids to be going to a district hospital. It doesn't make sense. It has to be as community-based as possible and delivered close to where people stay. So therefore, the role of peripheral health workers becomes critical here. And actually, it has to be completeness of care. And I would say one other thing, proactive care. Expecting that people will follow up with hypertension or diabetes in a district hospital once they are started with treatment there is a nonsense idea. It has to be provided proactively. And if someone is failing to continue treatment, then the system has to sort of go to the people rather than expect people to come up. Next. So cultural wisdom has to be respected. And finally, obviously, work on social determinants is as important, without which there is no primary health care. So our focus, if I may call it, that what we took on in our own area of work was we decided to work on primary common and important problems with equity and affordability as our pillars. We started working on the determinants, and using technology, and cost, quality, and access was very important concepts. Next. And it's very clear, primary healthcare is not primary level care. Secondary care and tertiary care are also part of primary healthcare, as it is very obvious now. And it is not a second, we should agree, primary healthcare is not second-rate medicine for the poor people. My child should get amoxicillin for a pneumonia, but a poor child get, cotrimoxazole. That is not primary healthcare. Or if I, I would touch on the leprosy thing. If you get leprosy in Brazil or in US, you would get daily rifampicin. But if you are getting leprosy in India, you get, or by WHO recommends once a month rifampicin. Are we different animals? That is not primary healthcare for me. And it is not straitjacketed.
Again, problem, Yogesh? We can't hear you.
Sorry, I'm back again. I'm sorry for this glitch. I'm in a slightly difficult place. So, these are not straitjacketed protocols and regimes. So, and I would say secondary and next slide. secondary and tertiary care are important components of primary healthcare approach. Let's not, trivialize them. Why should the public health system not provide this? Are they not the needs of the poorest, or are they only needed by the rich? This is a nonsense idea that has been going around even in our, even among our own set of people. And I really need to sort of take it. So let me take some examples for that. Next slide. Say, for example, snake bites. Certainly prevention and is something that we'll do at the community level. But if someone requires a ventilation for a crate bite or a cobra bite, that is secondary level, at least care, secondary level care. And sometimes it may be tertiary level care, say dialysis, or which is also secondary level care, but it is needed for people with viper bites. That is also primary health care. Malaria, obviously surveillance, prevention, as well as, ensuring early diagnosis and treatment is a primary care idea, primary level care idea. But if you require, intensive care for severe malaria, then that secondary to tertiary care may be needed. Diabetes type 2. Diabetes type 2, obviously, you require, screening for type 2 diabetes, and then you might require treatment to be started. Then, exercises and preventive care has to be done. But if you get a bad diabetic foot, then you might require a surgery. And if that surgery is not provided for, then this is not done. This is also, that is a secondary level care at least. Next, anemia and pregnancy. Anemia and pregnancy, you require certainly to prevent it. If you can, understanding the pregnancy, anemia, by the proper investigation. And then when you require treatment, you might require, even tertiary care. So these are examples that, we need to work upon to understand that secondary and tertiary care are also primary health care. Next. And depression. Depression might require diagnosis by a PHQ2 or PHQ9. But when you require care for severe depression, then this requires outpatient level secondary care by a psychiatrist, or, and there may be other levels of care that is needed. Good counselors are also not available at a primary healthcare level. So, public health interventions in the past have been based on, baseless assumptions of excuses of size, complexity, and expense have been given, which we should dispense. And this has been also a problem of GOBSAT. Good old boys sat around a table and decided on interventions. They never consulted many women and, women public health people, and then interventions were often made, nonsensically. Next. So let me take an example of tuberculosis. We are taught about tuberculosis as it is a bacterial infection that affects the lungs and all. This is the poor idea of understanding tuberculosis. It is diagnosed by sputum examination. Or the next, can you press next? Next. So tuberculosis is a disease better described as a consumption, a disease largely affecting young adults among the poorest communities. This type of understanding is needed for primary healthcare approach, where, because the body defense systems have been affected due to food deprivation, HIV, or diabetes. And it can be best managing the determinants. And by using a person-centric approach, this is something that we sort of have taken on in our work. Next. This is a patient who came to me about 15 years ago, who weighed all of 28 kilos at the age of 52. And, or a family of 3, at the same time having open tuberculosis, the father, son, and the daughter. Next. And, when we, if I may show this, next. Move faster. Next. Family of 3 with tuberculosis. So, when we look at the data of 5 years, about 15, 20 years ago, look at this thing. Median weights means that 49% people had even weights lower than the median, which is 42 kilos among men, adult men. And, previous slide, please, not this slide. And the average, the median weight in women was 34 kilos. Imagine 49% women had even weights lower than 34 kilos. My daughter at the age of 10 was weighing 34 kilos, and these are adult women with, tuberculosis. So, imagine these are the heights, and these heights were also low, but not such frightfully low. And 60% people had BMIs lower than 16 also. And 88% people had BMIs lower than 18.5. If this is what is tuberculosis, how are we going to look at only by, sort of doing primary level care, primary healthcare, primary level healthcare, or by without just looking at, treating people with tuberculosis. Next. So appropriate technology in healthcare is also needed, as I said, for even the primary healthcare. They can be aids and appliances. They can be information technology, which may include apps and databases, decision support systems. Next, ideas and practices. And if I can just 2 examples that I can show, how do I know that the water that we are all drinking is potable or not? So we developed a test based on a DRDO technique to microbiological test people who, next slide. So we could incubate water against our body's temperature as the incubator, and the color would turn black because of the color indicator if there was H2S, produced by Clostridia, which are surrogates for Clostridia, for for coliforms, which would tell that there is fecal contamination. So this technology could be used by the community to check whether their water is fecally contaminated or not. And or next slide. Next. So, this is a teaching stethoscope that a single piece, test piece, is having 2 sets of earpieces, one for the trainer and one for the trainee, or one for someone who's, the teacher or the student, whatever. And they can, you can learn together. So this is also technology that we use in training. Next. I would end by saying, this, primary healthcare, also like universal healthcare might seem like a, like a pipe dream, with all the big things that I've talked about, empanelment, comprehensiveness, acting on the determinants, using technology. But I would still say, there is hope in it, because there is no other way except to say this thing what Dushyanth Kumar said once. कौन कहता है कि आसमां पे सुराख नहीं हो सकता? एक पत्थर तो तबीयत से उछालो यारो. For those who don't understand Hindi or Hindustani, would say, who says that the sky, the firmament cannot be breached, cannot be, one can't create a hole in the sky. You should at least learn to with full interest and passion, at least throw a stone up. You might see that the sky might break. Thanks for hearing me. Sorry for the glitches that I've that we had due to my mistakes. I would be happy to take on questions, whatever you may ask.
Jason, you may go ahead.
Hello? Yes. Hello? Am I audible?
Sure.
Yes.
Audible.
I invite Dr. Sairu Philip, HOD, Kottayam Medical College, to comments on Yogesh presentation. Whether Sairu is here? Sairu, madam?
Yes. Thank you so much. Can I put off my video, because in case the connectivity is... Can you hear me? Okay.
Yes.
Okay. First of all, congratulations, sir, for expounding on primary healthcare, on universal healthcare, on the grim realities, the whatever you say, the grim realities or on the ground facts. You have stated it all. And thank you for helping us with the outline of primary healthcare and universal healthcare. And with regard to my comments are not in relation to what Yogesh sir has spoken just now. I would like to say that for me, when I hear primary healthcare, there are some things which is enticing to me, in the sense, maybe being in Kerala, having been exposed to the health system in Kerala and the local self-governments in Kerala, I think I'm much more optimistic with regard to this. Primary healthcare for me, it's a whole of society approach, okay, to attain the highest possible level of health. And actually, I learned primary healthcare from the community-based palliative care movement way back in the 2000s, because there I saw all the 4 principles were there. equitable distribution, appropriate technology. When you go to patient's house, when you don't have your pads, dressing pads with you, you ask them to sterilize it in their own puttu chamber, whatever it is, that vessel. So appropriate technology and intersectoral coordination. You require intersectoral coordination. And above and all, community participation. I would like to highlight the word community participation because I believe that if we want to make primary healthcare meaningful, this community participation is essential, be it for preventive, promotive, curative, rehabilitative, and palliative care. So community participation is the key. People realizing, I think Sir had pointed it out in his triangle. It's some that triangle that can move the world, the social and civil movement. So community participation, how we can ensure community participation. And in Kerala, the power of the local self-government and the decentralization since the 1996, I think things are much different. Even though there could be criticisms, I feel that things are much different. And if there is a local specific problem, now we can address it. And community participation, of course, the challenge is that how can we bring about community participation so that we can meet all the challenges that you have shown us, be it in case of NCDs or communicable diseases. So that is what I thought. Again, when we think about our future, now from health, we are moving on to well-being, happiness. So for all this, I believe that there is need for community participation. And that is one of the things in primary healthcare. And the Astana Declaration, it has refocused on it and refocused on community participation and has told that the youth, the participation of youth is very much important. So that is where we have to, that is one point where we have to focus on. And maybe with regard to universal healthcare, it came as part of the SDGs towards the goals in 2030. And one line which entices me here again is leaving no one behind. Okay, leaving no one behind. So how can we, with community participation, leave no one behind? How can the current, what you call the grim realities can be overcome by mobilizing people, the power of people-centeredness, the power of people? How can we bring it into it? That is where the magic lies, I feel. And one more comment which I want to make is, with regard to medical education, things are changing. Of course, privatization is there. But again, things are changing. The new curriculum brings in new hopes. There is the family adoption program where you need to adopt a family, each student needs to adopt a family and follow them up for 5 years. And they're coming face to face with the grim realities and how they can change it. So that is an avenue. Again, 8 core module, which teaches about professionalism. I'm not saying that everything is perfect, but these are there. And maybe the word, what I have to finally say is, the final thing is, who is the champion who is to bring about the change out of all this, out of all these concepts, leaving no one behind. Making primary healthcare approach meaningful. I think the champions are all of us, each one of us. And that is where our challenge lies. With all the coming challenges, with everything that is yet to come, I think we need to focus on there. And I think many of us are from community medicine. And I would like to say that we need to teach our students to make changes in the community with the whatever new things that have come in. And we have to work with communities in order to be really convinced about it. So my final and maybe the whole point is that community participation or engagement is the key to success of any program, and how we bring about it, how with our political commitment and maybe with the local self-government, the community, and a very proactive health system. Okay. And that is where our challenge lies. And I believe that our health system is becomes in where primary healthcare is very good, the health system is resilient in order to face newer challenges. So these are some maybe very starry-eyed, but I think there is, for me, it holds a lot of excitement.
Thank you, madam, for your precious words. Next is the audience time. Those who are asked questions, please raise your hands or put your comments or questions in the box, chat box. Then Yogesh, one comment, one question is here. What is 4x4 model? Hello? Dr. Yogesh, are you not able to hear? One question is, what is 4x4 model? I think Yogesh connectivity is lost because he is living in a remote area in Bilaspur district. The net connectivity is very poor, I think so. Jagadish, you can add some comments about the presentation.
Let us try to get Yogesh and.
I'm there.
Yeah.
Yogesh, one question is about what is 4x4 model?
Sorry, no, that
4x4 model.
Yeah, this is the WHO idea that they thought that NCDs, non-communicable diseases, there are only 4 that are important, and there are 4 so-called risk factors that are important, and rest is not important. And the 4 risk factors were obesity, high sugar, high blood pressure, as well as lack of activity. And the 4 diseases were diabetes, hypertension, cardiovascular diseases, and cancers. So this was a very sort of a poor idea of poor understanding of the entire spectrum of disease, and therefore a completely a non-universal idea that WHO sort of foisted on all of us.
Okay.
Yogesh, somebody else asked about
Leela Varki raised the hand. Leela Varki, you can talk.
Yes, thank you. Can you hear me? Sorry, I'm driving, so it's little. I've stopped.
We are audible. You can.
I think I have been in many discussions where the limits of what is considered community participation have been discussed. There's a sense that community participation is a word which actually leads to elite capture, where only a few people considered community and then they continue to participate in issues even when they are not the community that is being served. So in light of that, I wanted to ask, what challenges do we have in measuring community participation and its influence on universal health coverage? If any of the speakers can, put some light on this, because this is really essential. Unless we have, good evidence, it becomes very difficult. It becomes just one of those feel-good factors. So where is the evidence, and how do you measure community participation? And how do you prevent it from elite capture? Thank you.
If I may try answering this, before the 2 professors of public health might want to talk about. For me, community, I don't think participation is the right word. I would call it community involvement and community basing of primary health care, which means that either that you have strengthened, you not only have health workers who are based in the community and who are drawn from the community, but also you have even the health systems the hospitals has to be sort of I would say communitized. Health services have to be completely communitized by either having peer support groups of people, patients if there are. But I would say even the knowledge base of about your illnesses, as well as what you even about the illnesses or about your own bodies, that has to be done at a community level, and there has to be an active transfer of power to from away from the health systems to the community, without which this participation is going to be, as you rightly said, is going to be only an elite capture. If not elite capture, it is only giving away some crumbs to the people. If I'm not.
Yogesh, next question is about the term GovSat. B. Raj from ICMR want to explain the term once more.
No. It was a tongue-in-cheek thing. GovSat, basically, there's no certain word. It's just I have coined it. Good old boys sat around a table. This is how decisions are taken by some people without looking at evidence, or without looking at they just what their immediate ideas are. a small, a club of people, and it often men, would decide for many public health policies are made like this. So I've seen this malaria policies being made by people who have never seen malaria and by people who are sitting in Delhi where there is little malaria, but none of the people from central India would be used. Similarly, for tuberculosis, decisions are taken without consulting people who are actually managing tuberculosis, but are made by this thing. So it was just a tongue-in-cheek comment about good old boys sitting around a table and deciding in a boardroom rather than involving all people who can influence decisions.
Hope that Biraj, it is clear. And Karthika Kalyanram, raise that hand. You can talk, Karthik.
Thank you, sir. Yogesh, thank you so much. Brilliant. Hello.
Bolo.
Yogesh, there's one more, I think, aspect to this is starting from school education itself. The concept of taking health into your own hands and not saying that it is a doctor's responsibility to treat me in full, whether it's a diet, whether it is early initiation to alcohol or drugs, or following the latest lifestyles thanks to smartphones. The whole thing of nutrition, food, addiction to the media, addiction to chips and Lay's packets. And I think in any village we go to in India today, the first thing greets you is this little shop which will have packets of Lay's hanging outside.
Absolutely.
So that education has to be there. That's
absolutely. Sorry, I missed saying this upfront. This is actually this is so critical. What you mentioned as an important component of a primary healthcare approach. Without which I think forget about a lot. You can forget about universal healthcare, but you can forget about primary healthcare.
True. Thanks.
Another question is from Deepa, role of LSGD, local self-government, in providing PSC. Can you explain it or elaborate it? What is the role? Role of local self-government, Grama Panchayats or Nagara Panchayat in providing primary health care center, primary health care.
I would say, any form of community basing of health services, taking power away from the doctor as well as from the from big hospitals or big health systems towards communities, and of which one middle path would be local self-governments, because they are closer to it is actually sharing power there. Why should why should people be governed by a district level officer? Why can't it be done at a community level, where all these other smaller things like not smaller other things like education, health promotion would happen. For example, at this moment, how many villages in India have a playground for men and women to sort of walk around in the morning? If you're talking about preventing NCDs and otherwise also just feeling nice, where are the playgrounds even in cities? Forget about, and even in villages, there are most villages that I have worked in, I don't see any playgrounds for adults. Even for children, there are hardly any. But so I think self-government is an important, there can be a very important locus of ensuring comprehensive primary care.
Thank you. Next is from comments and one question. Rajasekaran Nayyar. Universality only address the equality issues, and if it needs to be effective, it has to be emphasize equity. I think the word care also directs it to service issues rather than addressing the cause of causes, including social determinants, thereby rationalizing an insurance approach. What is needed is an alternative vision paper on universal health. What is needed is an alternative vision paper on universal health. About it, your comments, please.
I agree with him. I think the fact that, but certainly even when it is even talking about health coverage, equity is an important underpin of that. But certainly when we talk about primary health care, for universal health care, equity would get in other aspects that my questioner has asked, and I think So I would agree 100% with him about the universal healthcare, but I would say equity is an important underpinning, even for anything short of universal healthcare also, something like universal health coverage.
Next is name not written. Can you please show the slide on definition of tuberculosis? Can you tell the definition of tuberculosis? That's one question.
Can you, no, this is a definition that I sort of wrote, but but the first part of that slide was, can someone run that slide on tuberculosis? The first definition was what an unwary doctor or a nurse would tell you about the diagnosis of, about the definition of tuberculosis. And the second was that what I sort of, what would be a better diagnosis, better, definition of tuberculosis. It's you have to base it. Can someone show that slide once again? I think it's closer to the end. I would show 40 number slide of 41.
Please, Arun.
Yeah, this one. I think, yeah, you're here somewhere close to this. Just above this, yeah, above that photograph. Yeah, this one.
Previous.
Full screen for this. Yeah, run it. Press enter. Yeah, this is the bad definition and the other is a good definition. Tuberculosis is better described as a consumption, not as a, a pulmonary or bacterial infection. Who gives a damn to whether it is a bacterial or not? Go back.
Barbie, on the comment
Yeah.
Dr. Jayakrishnan, we need not go for reading the detailed comments, it seems. It would be better if we can go for some discussion and so that people can come forward and ask some question or comments. Okay. That would be much useful, it seems.
Yes.
Yeah. Yogesh, Jagadish,
please raise hands and comment.
Not exactly a question, Yogesh. I have been to your place, not to your current place of Sangwari, but Jan Swasthya Sahayog. So, would you please elaborate?
I remember that.
Elaborate upon how it was started, which way, the way I saw it here, saw it there that it was functioning, very well functioning as secondary level hospital like, and you have community level linkages, community level programs. And just like your water quality test innovation, you have so many other innovations.
I'm back.
And also,
would
you please elaborate upon how it was evolved, how the JSS or Sangwari was evolved, and which way your practice, public health practice and the clinical practice is different from whatever is happening in the government sector or other private sector?
So I would say, that it's actually not an important thing, but because, so it was, I and a few other friends had been trained as, technicians, technically competent doctors, but were worried about being, better doctors only that time when we started work. But I think we acquired our political learning about primary healthcare, about healthcare overall while working. Frankly, we did not start with a good understanding about the politics of political economy of health, which actually I learned only after I had sort of made this thing. But the only good thing that we had was we were good learners about we were good observers in the community, and we were not also prisoners of of certain knowledge base in politics or economics, and we learned all this while working, and even and that allowed us to sort of even innovate in primary healthcare and even take on questions. And then by the fact that many people sat together to discuss things and find answers to questions, we I think this entire idea of debating and discussing questions, answers to public health questions, actually allowed us to be successful, if I may call that. And I think largely, we just have learned over the years what actually is needed. But I don't think we have been very successful in doing much beyond serving the communities that we sort of focused our work in, even though it was over 1 million of population. But even at this 25 years later, I feel we could be, we would really like some of the ideas that we learned about primary healthcare, succeed. But Anthony is here, he would know how difficult it is to change, policies and practices. Dr. Anthony is, who's been a comrade in Central India for some years, and so many others at MFC, where we have debated about these. But more than just understanding our own, making our own understanding and serving a few people, we really haven't been too successful at a larger level. Yeah.
Anthony, you can talk about that.
It cannot be heard.
Policies of the government, and along with and I
You are not audible. You are not audible.
Very feeble, Anthony.
Okay. So JSS has been very instrumental in influencing the government along with the State Health Resource Center Chhattisgarh also in bringing about so many pro-poor policies. See, for example, even allowing the food rations for TB patients initially in Bastar district, later on to Sarguja division. Based on the nutrition is such a important growth factor in the treatment outcome of such low BMI patients. That is one thing. So complete revamping of PDS, and also on the people not to outsource lab diagnostics to private parties, and the whole selection and training of vitamins, so many other things, and the use of appropriate technology at grassroots level. So they were very instrumental in that, and hats off to the JSS team on even WHO bringing out with the module, Dr. Anurag and Madhavi and all, on the importance of nutrition supplements for TB care. I would briefly add to Dr. Leela Vorkey's that question on what do you mean by community participation? Just briefly for fine. The community participation was initially by the government's perspective, it was I operate, you just cooperate. That is, completely there was a paradigm shift with the National Rural Health Mission launching. It is that communitization, one of the 4 pillars of the National Health Mission, National Rural Health Mission to start with, and that is initially by a selection and training of a community level health activists in the name of ASHA based on the Mitanin model of Chhattisgarh. Number 2 was the formation of village health, sanitation and nutrition committees to ensure the other health linked factors like water, sanitation and nutrition as a agenda, concomitant agenda of health delivery system. Third was the Rogi Kalyan Sanghi system. But the Rogi Kalyan system, Kalyan bodies, samitis, really it was tokenism and representation. As real community participation is envisaged, it doesn't represent the unspoken, marginalized communities. Number 1. Now, the Rogi Kalyan Samitis at district level, as Leela Vorkey really said, it was the elitist, some representatives occupying that seat. And it was mainly came down to the level of just purchases and decisions on hospital, civic facilities and some.
Sorry, I think Anthony connection is lost.
I would just like to add on to, Madam had asked about community participation. How would you measure it? I believe that community participation, what I talked about was in a broad sense, not in the, what do you mean, the technical sense. You can measure community participation by certain indicators or through qualitative approaches. That is one thing. But then when you really mean community participation about that elite capture, sometimes in certain contexts, the elite may be missed out from that participation. That can also happen. But I believe that whatever we were speaking about of an empowered community who has the power to participate, power to decide, and power to change things, decide what they need in their own area. That is the sort of community participation. You can even call community empowerment or community engagement. It doesn't come from somebody outside. It sort of evolves from within. That is the sort of thing that can bring changes. Thank you.
Yes, any other want to speak and talk? The chat board is filled with so many comments from all over India. I'm not going to read it. Anybody want to ask questions or comments? Please, can talk.
There was a question on why not think of NHS UK model, UK NHS model. There was what is happening to NHS. Yogesh, if you would like to, you can.
So I think NHS is a great model, but it obviously is expensive. And, and I must say, even though people are berating about NHS, in UK, no one wants to give it up. And I think, opportunities like what NHS came up in 1946 because of post-World War II. I think, we have a war almost at any time in the country in India that we are with our health situations that we are in. And I think, more than the NHS, what we should learn from is from Thailand, how it is done. A country that was 80% rural in 1976, like India, has been able to do this. Obviously, they've put in more money now. They're now in a middle-income country now. But I think we should learn from all these people. And we know actually what is needed to do, how much money is needed, and how to do this, but we don't have either the will to do it, and secondly, there's also a little expression over the demand for this thing, and in which we guys activists have in a way have much more work to do.
Can I speak? I was asking the question about NHS.
Yes, Vasudevan, you can.
Yes, I am a practicing physician in Kerala. I was there and my own personal experience in Kerala. Because the most important problem that we face in Kerala is super specialization and individual disease specialization. In the rural area, the people are asking for a headache, they approach a neurologist. For a chest pain, they are approaching a cardiologist. And nowadays, the people are asking, is there any specialist for a uric acid or a specialist for sodium? So these types of approaches are there in Kerala. And for the last year, see, Kerala spent about 13.5 crore rupees, 13.5 thousand crore rupees for the medicines. And the problem in Kerala is super specialization, and this can be avoided simply by implementing universal healthcare. Actually, in 2012, Srinath Commission also said that this has to be implemented in India. But most of the states, they are not giving importance to health. And the government also, they are spending only 1.2% of the GDP for the healthcare. So this has to be changed, and universal healthcare is implemented so that a man can approach, a patient can approach the primary healthcare for their illness, and if there is if it is needed, then they can approach the secondary healthcare or a tertiary healthcare. Now the people are directly approaching the tertiary healthcare for their disease. So this type of scenario make lot of money expenditure, lot of time expenditure, lot of investigations. Now a study said that there are nearly 22 MRI scans are done per day in a center. Round about 522 scan centers are there in Kerala. So you imagine how many MRIs are done per day, and how you imagine how many endoscopies are done per day, how many CT scans are done by, and most of the people having chest pain, they are undergoing unnecessary coronary angiography.
Dr. Vasudevan, be brief. There is another hand raising, Manju Reddy. So please conclude.
Okay, I am concluding. So what I am
Okay,
telling
so
is that
I would answer this immediately by saying that, you know, this is obviously not far away from universal healthcare. You know, if we had a strengthened, you know, a strong predominant public health system where the primary level care provider would be a gatekeeper for, you know, going to secondary and tertiary care or to a specialist care, this problem would not even arise. And the second, so obviously the second bit is, you know, in a very privatized world where, where it is a market economy that is determining, care provision and care access. These problems are not going to go away. So you need a good, strong public system to be doing this, and the private system has to be held in, in check completely. Otherwise, this nonsense that you are observing in Kerala would also happen in other cities in other states, in some bigger cities of bigger states, and even it might percolate to the care seeking might even get altered in poor people also. But I think both those things, primary care being gatekeepers for reaching secondary and tertiary care, as well as restraining private systems development at the cost of public systems, poverty.
okay, thank you.
Dr. Manju Reddy, you can talk now.
Thank you for taking my question. Dr. Jain, you made a very inspiring presentation, and you referenced Right to Health Act, in parenthesis care. And you also mentioned that until 2010, you hadn't heard of the word universal healthcare. Could you please expand and also share your wisdom on what if we start this process, or if you have started the process of bringing up awareness about right to health care? Thank you.
It's out the last question, the last bit of the question. Can you just repeat it once again?
Yes, Dr. Jain, I wanted to know what your efforts have been so far in conceiving or in even taking this forward, this Right to Healthcare Act.
So yeah, we have been, debating about this in Chhattisgarh, where I work, because at the national level, given the political environment that we are in, right to healthcare doesn't stand a Right to Healthcare Act does not stand a chance at the moment, or hasn't stood a chance in the last several years. We saw
Again, some connectivity issue. Seems Yogesh Jain is.
Formally as a justiciable act that is severely opposed by Indian Medical Association and the private hospitals lobby there, and it is temporarily kept on hold. Yes, Yogesh.
Tamil Nadu also decided to have a Right to Healthcare Act, but it has also got stalled because of pressures from the private sector or from other people in the political establishment. So I think I think we all need to work on this. As of now, I think our best hope is to work at different individual state levels and learn from the implementation in different states and then go about it. I don't know whether Kerala has the appetite to get into the Right to Healthcare Act, but I wouldn't say that, because I understand in Kerala there's also a very strong, dominant private lobby who will sort of, ensure that, all the people don't collect together for a legal right to healthcare. But if we can succeed in Kerala, I think a lot of people will learn. In Chhattisgarh, at the moment, I don't have much hope, but we are still working hard on it. I would.
Dr. Yogesh, in this series, we have a special session on right to health, and in which Abhay Shukla and Chaya from Rajasthan, where the act was implemented or enacted, they will be participating. And
yeah, I think that's a great idea great thing to discuss. You should get the Tamil Nadu people also to come in if you can.
Since I would like to, I'm Jagadish, and I would like to add some point related to primary healthcare model of USC, which was tried in Kerala. I think what we tried in Ardhram phase 1, that was in fact an attempt for a primary healthcare model of USC. In fact, after the HLEG report, immediately there was some piloting of the this primary healthcare model of universal health coverage in some of the selected institutions, and effort for streamlining the elements of primary healthcare, incorporating even the learnings from NHS. Some of the consultants were involved, and they actively got involved. And in 2016, when these family health centers were started establishing, there the whole horizon of the primary healthcare was expanded, and the type of care services, everything was expanded, and newer service delivery components were added, and the human resources were expanded, and the community involvement and everything. So it can be taken as an effort for, and still Ardhram phase 2 is continuing. Since I got retired, I'm not in a position to say much about that, but that was a primary healthcare model of improving the healthcare or universal health coverage. And in fact, the NHS NSS data shows that there was an increase in the people's turnover in the primary healthcare institution. Since I was also part of that program, I thought I will add that the role of the LSG, Panchayati Raj system, which we discussed in great detail, but this part also need to be added, in my opinion.
I think public health institutions' utilization rate during the COVID time has increased from 14 or 16% to about 48%. So that is real community utilization. And sorry, when I was making the community participation and involvement in universal healthcare, there is an enabling environment in Kerala because of the local self-government involvement. And what is most important, an ornamental community representatives in hospital management committee, it can be improved to really wider bodies on not only the equipment purchases or staff, contractual staff employment, but more to the quality of service, and even the award of Calicut by National Health Mission, the community voices, and the youth, and also the consumer redressal forum or patient grievances forum, where not only the political leaders like MLAs and all coming, or block panchayat president and others getting involved, but really some lower level community representative user group taking their voice. That is, I find a good scope in Kerala for that. Thank you.
I am Feroz here. Can I ask a question to Yogesh?
Yes, Feroz, you can ask.
Yeah. The thing is, what I understand is in Kerala and Tamil Nadu, probably there is a lot more of government involvement, and there is a basic structure that is in place as far as primary healthcare is concerned. But you go to northern India and in various states, it is not there. The government involvement is much less, and the people are in disarray. In the introduction of Yogesh, it was told that he left his job in All India Institute and he has come to Chhattisgarh and trying to put in place a primary healthcare. Now, what I want to hear from Yogesh is, how much did this experiment go along? In the sense, could you put a system in place as far as the primary healthcare is concerned in a place like Chhattisgarh, where the government involvement is much, much less than what you have in South India. Your presentation was more of an ideal situation of primary healthcare. But how far can you take that to reality at the ground level in North Indian states, particularly like in Chhattisgarh? Till how far could you go as far as the system or an infrastructure could be put in place without the help of government? Could you go much beyond?
Yeah.
Your
So no. So Feroz, your question is, and in fact, I had partially answered that earlier. These last 25 years of struggling in Chhattisgarh, we've been able to, develop an alternative thing outside the public system to provide primary health care. But our ability to influence the public systems, practices or even their policies has been, only, very early steps have happened, and I would not call that success at all. And I'm not, I continue to be hopeful because I think people can collect together and demand things and even force political will. But as of now, it seems like a long haul, and I think you guys in South India are far ahead of of that sort of a thing. Northern states are not just northern states because of because they're they're higher in latitudes. It's also there's so much of nonsense that happens, and politically we are we are far poorer in northern states, not just in terms of the party that we choose, but also the way we think about society as the concepts of even equity are much poorer in northern India, in states of northern India, and so is the discourse. Yeah.
To put it another way, is it possible to have a system outside the government sector? Did you think about that? And
No. I don't know. No way. It has to be public system provided. If you want to give UHC, there's no question. There's no other way but a public health system run by the state, in a sense, or by the community, which can't happen. Community can't run health systems at secondary and tertiary care level.
Okay, thank you.
And Dr. Krishna Kumar from Calicut. Dr. Yogesh, I'm also a pediatrician and a psychiatrist. Actually, I was wondering whether, especially when Feroz was talking about and Jagadish was talking about Kerala model and all, is it possible to have a uniform pattern of primary healthcare system for India? Because the conditions are different in different states.
I don't think it can be similar. The principles can be similar, but not the details. Yeah.
I think especially what Dr. Chandrasekharan was talking and many others were mentioning. So the South Indian states have a different situation. So I think when we plan the national programs, there also should be a method to introduce regional variations or something which is suitable to regions.
Yeah. Yeah.
Dr. Kumar, Yogesh agrees with your comments. He said yes.
Absolutely. Yeah.
In between, can I make an announcement? Our next program is July 4th, and the topic is healthcare challenges in war and conflict zones. And there is one international presentation from Palestine, Khadija Abulkar, Public Health Officer in Palestine, and another national, the same issue at Manipur. The presenter is Shem Rayomi from Delhi. We can continue the discussion. Yes.
Anybody else, any question, any comments? Or, it's very difficult to get Yogesh Jain for a discussion.
Yogesh sir, how sustainable will be the efforts that you have put in for over maybe over so many years, so many decades?
I don't know. As long as I sustain and I can sort of, we are working on this. The ideas don't sustain by just individuals. The processes that have to be put in place to sustain. Obviously, there are many challenges, as I pointed out, for that there are, but there's no way but to sort of work on continuing with these ideas, and you can't just stop because it's difficult. That it is difficult to sustain. I think we all keep on struggling, and gather our strengths and put our disappointments behind us, don't we?
Can I ask a question?
Yogesh, few words about Janasastha Sahayam and Sangvari.
Jagishan, Mira Shiva is asking some question. Mira, please go ahead. Mira.
Yeah. Yogesh, so nice to hear your voice.
And
to see you, even though the net was not behaving itself too well. Talking about the essential drugs, you put it as one of the major points for universal health. You know that all that fiasco about oxytocin causing infertility, etc., and that banning and all. So now I just wanted to ask, since you're working in the field, that medicines for maternal health, reproductive health, women's health, children's health, like tuberculosis, talk out and problem with procurement is there. But how is postpartum hemorrhage being managed? Because if people had been trained, health workers had been trained where oxytocin used for postpartum hemorrhage. Suddenly something else is introduced, and how much training? And not just in your area, but you would be knowing in other areas. And also this HPV vaccine being given as a policy for which Mr. Bill Gates is quite excited about. And also not only excited, he's sort of proposing and promoting, and he has investments in many vaccine companies. That's another story. So your non-humble views about this.
Wow. So I about oxytocin, I think, frankly, there has been often a shortage of oxytocin. There's no doubt about the fact that oxytocin works, and it is, it just requires refrigeration, and there is now a heat stable, which is, but it's 20 times more expensive than the heat stable, what is called carbidocin is available now, but that's so much more expensive. So oxytocin still works, and it is very good. There's another drug on the block called tranexamic acid, which is also being used in postpartum hemorrhage. But oxytocin is cheaper and easily available at the moment, and I don't see a problem at the moment in Chhattisgarh at least, and in Madhya Pradesh. About your question about HPV, I am not a person who would believe that HPV has no role. I think it has a role, but it has a role in addition to screening, which should be done first. And in a pecking order of importance, I think screening has to happen first, and screening and then treating people has to for dysplasia and something that should be done. Then only one should get into a program for HPV vaccine, and if at all it has to come, it has to be universal. It cannot be made available for some people who are rich, or it can't be made available in the private sector only. It has to be a public systems vaccine, and then I think then it has to be only then. But once screening programs for CS cervix are in good shape already, if they are not, then I don't think getting into a vaccine program makes sense at the moment. Over.
Screening with acetic acid, dilute.
No, there are now better ways also. HPV DNA technique is there to check for that, but that's expensive. Only if you get an economy of scale, it will become cheaper. But yeah, that's more reliable than HPV than VIA.
Thank you. Keep in touch, and we want to hear more of your things. And see you.
Okay.
And thanks to the Kerala team for organizing this, Jagdishan, and all the Calicut group, MFC group. Thank you.
Thank you, Meera.
Jagdishan, I want to get share a few words about the Genesis of Sahav and Sangwari. Yogesh,
Sure.
please.
Oh, sure. Go ahead.
About the organization, your organization.
So, as I said already, Jan Swasthya Sahyog was formed in '96, where some of us, physicians who trained in Delhi at AIIMS, went over to Chhattisgarh to work to develop a primary healthcare program. Obviously, primary healthcare approach program. So there was also secondary and tertiary care being provided. So, I, along with my other colleagues, worked there for about 20 years. The organization is still working, but I decided 4 years ago to move to a more difficult area in Chhattisgarh, which is in North Chhattisgarh, called Sarguja, closer to Jharkhand and eastern Madhya Pradesh and southern Orissa, where we now run a program for last 4 years, again using the primary healthcare approach, called Sangwari is the organization. There are 7-8 physicians also, but much younger physicians who are grappling with this idea of how to work in a group and how to work effectively in providing primary health care. Early days for them. I'm there as a slightly gray-haired senior for them to support. Yeah.
Okay.
I think we have to really appreciate the work Yogesh is doing. It's a great motivation for the youngsters if they are hearing this.
Stamina, resilience.
And hope to meet you.
Yesterday, somebody put a video of Yogesh speaking to maybe young generation medical students or thing like.
We didn't see it.
Very motivating.
Where was it, Jagdishan? We didn't see it.
That was in the group, and anyway, Jagishan, we should upload it in the larger group since there are two groups.
Please.
Okay.
Hope to meet you in Calicut in August.
All right, sir. Yeah.
Yogesh, welcome. Because we are all very much eager to listen to you.
Okay. Have to try that. Yeah. Okay.
So already it is
15 past 9.
Yeah,
Yeah,
15, and so anybody else, but still 70 are here, and so anybody else want to anything, and if Yogesh want to add something, then we can.
No, I have spoken a lot today. Thank you. I usually
Thank you
don't
so much. And of course, you have these technical difficulties, and since you are sitting in Chhattisgarh, we know.
We want to hear more from you.
Yeah.
More and more appropriate technology. As far as a public health physician want to know the appropriate technology developed by your organization and practice in the field.
Yeah. Agreed.
All right. Some other time. Okay. Thank you. Thanks for having me. I love being, MFC is where I cut my teeth. So it is great to see.
Yogesh, I was just remembering some of our MFC meets when Satyamala and all were there in Delhi.
Yeah.
When, at that time, you were in AIIMS and we were in JNU. So if nobody else is speaking, then
you can wait
we... Thank you,
and
Yogesh.
inviting all of us for the next program.
Okay. Thank you so much. We are all enjoyed.
Jagdish, every Thursday we are continuing this program. So hope that you will be with us.
Right, sir. Will be.
And a very big thanks to Yogesh Jain for staying with us with the past 2 hours. And thank you all the active participants all over from India. Thank you.
I want to say finally, healthcare for all is a socialist project. Full stop. I don't think this is, I want to say it once.
And also thank you for the Arun for technical support, IPM. His IT person IPM for his technical support.
And as discussed, Dr. Saidu was there, and that was also
Saidu also. Due to some other problem, Asma madam informed her inability to attend the meeting.
Okay. Yes, great presentation. Thank you.
Bye.
Mira, good to see you.
Good to see all of you.
So thank you, Yogesh and everybody. Bye-bye.
Okay. Bye. Good night.
Bye.
Okay.
Bye.
Bye.
Bye.